Topic of the lecture today is systemic mycosis. Now, first of all, before we deal with systemic mycosis, we have to know what mycosis is. Mycoses are actually infections caused by fungi, which can be of different types, which can be of different shapes, which can be in different forms. But what we deal with in systemic mycosis and the types of it, or further subtypes of it, are dimorphic fungi. Now, you must be thinking what dimorphic fungi are. Dimorphic fungi are those fungi which can live as a mold and as a yeast in both types. They can survive in both types. It depends upon their temperature. It depends upon the temperature they're inhabiting, right? So what happens is that any kind of hyphae which is present on the soil is going to produce round celled and round shaped structures which are called conidia. Now those conidia are going to be airborne. They can be airborne. They have this capacity to disseminate fungi. I mean, when we talk about fungal infections, when we talk about systemic fungi, the first thought we ultimately get is that how these fungi are getting into our systems. What's their route of transmission? So what happens is that fungi are basically present in the soil, they're present in the plants, they're present in unconsumed food, which has been there for a long time. What happens is with time, fungi develops in that, hyphae come into the existence, and when hyphae are there, what they do to disseminate fungi is that they produce conidia. Now conidia are round shaped and they are very light and they have this capacity to disseminate fungi. How? By air spread, right? So they leave this hyphae and they're airborne. What happens is that we inhale them. When we inhale them, that's how we get them into our system. It's not going to be any other route rather than this route. 95% it's inhalational route. So at 25 degrees centigrade or lesser than that, it was present in mold form, right? It was present in mold form. This fungi was present in mold form in the soil. It was cultivating that soil in the form of mold. But what happens is that when the those conidias get entry into our nasal systems and go into our respiratory systems, go into our lungs, what happens is that at body temperature, they develop into yeast. They transform into yeast, and the further development process of their whole lifeline goes along as a yeast in our body. So that's why they're called dimorphic fungi. And in systemic mycosis, in this lecture, we're going to talk about exclusively dimorphic fungi. Those fungi which are present in hyphae form, which are present in mold form on the outside, but when they got entry into our system, they transformed, they transferred into yeast form. And then they disseminate into blood, they get into other organs, and they cause systemic illnesses, which we call systemic mycosis. So what are the basic subtypes of mycosis? What we have to know is that what are the basic subtypes of mycosis and where does the systemic mycosis lie in that? So there are basically four categories of mycosis, basically. First of all, we have Phaeohyphomycoses. Second, we have opportunistic fungal infections. Third, we have endemic mycosis. And fourth, we have superficial cutaneous infections. Now, these are the subtypes of systemic mycosis, meaning that these are subtypes which are one way or another way going to cause illness in your systemic, at your systemic levels. So, first of all, we have these Phaeohyphomyces. Next one, we have opportunistic fungal infection. What are opportunistic fungal infections? Opportunistic fungal infections are those fungal infections which occur when the patient is immunocompromised, when the patient is taking immunosuppressants, or if the patient is already suffering from a chronic disease, already suffering from a chronic infection. That's when these fungal infections come into your body and cause these infections, these fungal infections. Otherwise, they won't even matter. The immunity will take care of them. They're not that strong to fight your immunity. But when you're already down, when you're already immunocompromised, when you're already taking immunosuppressants, or under the influence of any other chronic illness, they're going to cause fungal infections. Next on, we have endemic mycosis, which is called by dimorphic fungi. We talked about dimorphic fungi, right? They can exist as mold, they can exist as yield. But in our yeast, in our body, it's yeast. Outside, it's mold, it's hyphae, it's conidia. Next on, we have the superficial cutaneous infections, which involve the cutaneous layers and superficial layers. They don't invade the deep tissue, they don't invade the deep cells, and they stay as superficial as they can, and that's why they are named superficial cutaneous infections. Now, these are the main categories of systemic mycosis. These are the main categories which will lead to systemic mycosis, right? So we have these opportunistic fungal infections, we have endemic, and we have superficial. Now, what is endemic mycosis? Endemic, pandemic, you might be thinking, is it related to some kind of epidemic? No, it's not. Endemic mycosis is caused by heterogeneous fungi, heterogeneous strains of fungi which are dimorphic in nature. Thermally meaning at different temperature, they adapt to different form of them. Like at 25 degrees centigrade, they're going to be mold. At body temperature, they're going to be yeast. That's why they're called endemic. And they contain further subtypes which are blastomycosis, coccidioidomycosis, and further on we'll talk about all of them in detail. So, first of all, let's talk about endemic mycosis, which is called by dimorphic fungi. What are the further subtypes of it? I just told you it has further subtypes. So, it has this blastomyces dermatitis. Next one, we have coccidioidomycosis immitis. We have histoplasma capsulatum. And we have paracoccidioidomycosis brasillinus. Now, these are the causative organisms of endemic mycosis. They can occur in two forms. They can occur in mold form, they can occur in yeast form, right? So it's not too far for them to cause infections in your body, because they are more likely to be airborne, they're more likely to cause illnesses in your systems. But one thing you have to keep in mind, studying all of this topic, studying all of the systemic mycosis, is that 95%, I repeat, 95% of these fungal infections are self-limiting, and they're not going to give you any signs or symptoms even. You won't even know that you are having this infection because the body takes care of it. 95% are self-limiting, meaning the body takes care of it. There are no signs, there are no symptoms. You won't even know that this illness is inhabiting your systems, but your immunity will take care of it. But in the rest of 5%, they're going to cause the illness. And what are the etiological features and what risk factors do we have in those 5% people? They're either immunocompromised, they're suffering from AIDS, HIV, they're suffering from cancer, or they're suffering from any chronic illnesses which might contribute to this pathology. So what we do know is that those 5% people which are at higher risk are those patients which are immunocompromised with some kind of chronic illnesses, with some kind of born illnesses, or they are found in the patients who take immunosuppressants. Third, they are found in the patients who are already suffering from this kind of illness. They're already suffering from another fungal infections, or they have been prone to fungal infections from time to time. So they are going to get that. So those 5% people that are at higher risk of getting this disease are these three basic groups. Otherwise, in 95% of the cases, it's self-limiting. Next on, we have endemic mycosis subcategories. What are the subcategories of endemic mycosis? We have Sporotrichosis, we have paracoccidioidomycosis, we have penicilliosis. So we're going to talk about all of these in detail. So first of all, we'll start with Sporotrichosis. So what are the etiological features of Sporotrichosis? It's a fungi. We know that for sure. We know it's of endemic type. That's second, right? We talked about the causative organisms of endemic mycosis. It's going to be one of them. So what causes Sporotrichosis? It's Sporothrix schenckii, right? Sporothrix, schenckii. That's how you pronounce it. That's the causative organism. That's the causative fungi for this pathology. Now, in this etiology, what do you see? What's in common? Look at all of these photos. Look at all of these pictures of different people doing different kind of work in different environments. What's in common? They're all subjected or somehow prone or somehow working in the fields. They're all present in the soil. They're all being subjected to the soil. We talked about that hyphae or fungi are most probably found in the soil. You can see they're planting, they are subjected to soil. They're planting, they're subjected to soil. All of these, these are picking fruits from the trees. We talked about that it's going to be found in the soil or trees. So he's also prone to that. He is subjected to soil. He is planting. He is flowering. She is other way subjected to soil because it's most probably taking care of it. Subjected to soil, subjected to plants, subjected to soil and plants. And what is this? A fruit man, a fruit seller, which has been subjected to what? Fruit picking, which has been subjected to what? Soil. So what happens? It can transmit this. That fruit is not being cleaned properly, or somehow there's some soil attached to it or some fungi attached to it, and you give away and sell it. It's going to get to another person one way or another, right? So these are the etiological features. And what we see in common here, what we have in common here is what? Soil and plants. These two are the etiological features for this pathology. If you're subjected to soil or plants in any way, you're going to get this disease. But if you are immunocompetent, if you don't have any chronic illnesses going on, you won't even know. It's self-limiting and it will take care of itself. Next on, let's talk about the epidemiology and pathogenesis. So, first of all, what happens? It invades your subcutaneous tissue, right? It invades your subcutaneous tissue and causes pathology. What happens afterward? It's going to move toward your legs, toward your bones, and it's going to cause osteoarticular sporotrichosis, right? You can see the involvement of the legs, you can see the involvement of the bones. Next on, it's going to cause what? Pulmonary sporotrichosis. And next on, it's basically seen in only immunocompromised patient that it gets to your blood, and disseminate. And it happens in what? HIV/AIDS patient. Let me tell you right here that sporotrichosis can involve any of these systems, any of these three systems. It can involve your skin, it can involve your bones, it can involve your lungs. But what's the primary target organ for systemic mycosis? I'm not talking about sporotrichosis. I'm talking as a whole about systemic mycosis. The primary target organ for systemic mycosis is your lungs, is your respiratory system. From there, it's going to cause some granulomatous structures. From there, it will disseminate into your blood and lead to other lymphoid organs, other lymphoid structures, other solid organs, and cause pathology there. But primary target organ is your lungs. Secondary target organ is your skin, and tertiary is your bones. So you have to know the preferences this pathology has on the basis of affecting. So it can affect your skin, it can cause subcutaneous tissue like this pathology, it can involve your bone and cause osteoarticular sporotrichosis, it can involve your lungs and it could cause pulmonary sporotrichosis, and it can disseminate in those patients which are immunocompromised due to any other pathology. So what are the clinical manifestations like? Just think about it. So the clinical manifestations are definitely going to depend upon what? They're definitely going to depend upon only one thing. And what is that? What system is being involved? It's either skin manifestation, it's either bone manifestation, or it's either your lung manifestation. If it's affecting your lungs, the clinical manifestations will be according to that. If it's affecting your skin, if it's affecting your subcutaneous tissue, the clinical manifestations are going to be according that. And if it's involving your bone, it's causing osteoarticular sporotrichosis, the clinical manifestations are going to be regarding that. So clinical manifestations truly depend upon the involvement of this pathology. What structure is being involved? What structure is being targeted? So that's how you know what clinical manifestation it will come with. If it's skin, it's going to be with papule development. Papules will develop. You can see the development of papules here. Papules will develop. Papules are what? Structures, these raised lesions which are filled with this kind of material. You can see the papule development will come in, which will ulcerate, but it's not painful, right? If you look at it, you might be thinking it must be so painful, but it's not. That's one way to identify it from other different kind of skin manifestations. So it will ulcerate, but it will not cause any pain. And what happens when it disseminates? It will lead to lesions on lymphatic channels. It will lead to lesions on lymphatic channels. Most probably the closest lymphatic nodes will be affected, but generally it can affect other ones too, and it can cause lesions in your different lymphatic channels. So what's going to be the diagnosis and treatment if you have skin manifestation only, or if you have lung manifestation, or if you have bone manifestation? First of all, you'll go for the treatment regarding your signs and symptoms. If you're having bone pains, you will get the treatment for pain. If you're having cough, if it's lung manifestation, you are going to get the treatment for that. But what's the general treatment? How do we treat sporotrichosis rather than treating the signs and symptoms? We will treat the signs and symptoms, that's for sure. But how do we treat sporotrichosis? What are the basic drugs used to treat sporotrichosis? First of all, to be sure about it that it's sporotrichosis, you have to diagnose it. How do we diagnose it? We'll go for the biopsy, or we'll go for the serological testing. Biopsy of what? Biopsy of those structures it's affecting. Biopsy if it's skin manifestation. We talked about papule will develop. You'll go for the biopsy of that, and you'll know it's sporotrichosis, and then you'll start the treatment. Other than that, you can go for serological testing. If it's not, biopsy is not an option. If it's affecting other organs or other internal structures, you go for the serological testing, and you'll know it's somehow it's a sporotrichosis, and then you'll start the treatment. And it's not like you're only going to go for these two tests. You don't know that it's sporotrichosis. You don't know it's a fungal infection. You will do all the baselines. And what are those baselines? You will start from your complete blood picture. You'll start from your hemoglobins. You'll start from your WBCs. You'll know what kind of infection it is. You'll see the neutrophil count, the leukocyte count. Every count matters. And when you have excluded the differential of bacterial infection or any other skin manifestation, you will ultimately lead to what? Fungal infections. And then you'll go for the biopsy and serological testing. So you will go for the baselines. You will go for LFTs, RFTs, and all the other modalities that we use in daily testing for excluding different differentials or even including some differentials. Right? So what's going to be the treatment? First of all, we'll treat the signs, then the symptoms, and next one we have this itraconazole, we have saturated solution of potassium iodide, we have terbinafine, and we have amphotericin B. Now these four drugs are very useful in treating sporotrichosis. In some patients, they're given in combinations. In some patients who are at high risk and who are under this active infection, maybe a group of 3 drugs is prescribed. But basically, you prescribe only one of them regarding the sensitivity of the patient and other different modalities which you have to consider before giving an antifungal drug. So these 4 are the basic drugs used for sporotrichosis, which are itraconazole, potassium iodide solution, which is saturated, terbinafine, and amphotericin B. Next on, we have paracoccidioidomycosis. right? What's the etiology, what's the epidemiology, and what's the pathogenesis? Now, in your mind, you'll know what's the etiology, what's the epidemiology, what's the pathogenesis. Whenever a systemic fungal infection comes into your questions, into any questionnaire, one thing you have to remember, we talked about that earlier. One thing we have to remember, it is dimorphic fungi. It's going to be in two forms. It's going to be a mold outside. It's going to be a yeast inside. What's the last one? That it's going to be caused by soil or plants. These 5 points you should have in your mind ready so that you don't have to think about what is paracoccidioidomycosis. What is that? What's the cause of this? If it's a fungal infection or bacterial infection or what. If you remember these 5 points, you won't even have to think about it. You will be very sure about its epidemiology, you will be very sure about its etiology, and you will be very sure about its pathogenesis. So, first of all, let's talk about the etiology. The causative fungi is paracoccidioiditis brasiliensis, right? This is the causative organism. What's the epidemiology of it? Most probably it's found in Central and South America. It's not found in Asia, it's not found in Africa. Most probably whenever you will listen to a pathology, you always go like it's found in Southern Asia, it's found in Central Asia, in African countries because they're not hygienic, but it has nothing to do with the hygiene, right? So it's found basically in Central and South America. Next on, how it is done, what's the pathogenesis of it? We talked about it. We talked about those 5 points that you have to remember. That it's going to be in mold form outside, it's going to be a yeast form inside. So how is it going to happen? You'll inhale those aerosolized conidia. We talked about hyphae are going to produce these rounded structure which are called conidia. These conidia are going to be inhaled by you. In the lungs, they're going to convert into yeast. And when they convert into yeast, they cause a pathology. They cause granulations, granulomatous structures, and afterward they disseminate into your blood if you're immunocompromised in some way, and then they cause different pathologies depending upon which solid organs or which lymphoid structure it's going to invade or affect. So that's your pathogenesis. It's going to be the same in every case. The route of transmission is going to be the same. The cause of all of these pathologies are going to be the same. If you remember these 5 points, which I told you, you will be good. So what clinical manifestations you'll be looking for in paracoccidioidomycosis? First of all, this is a major syndrome. You'll have active or juvenile state or chronic or adult stage, right? In acute or juvenile stage, what happens is that age is always less than 30. It's going to be disseminated infection of reticuloendothelial system, and it is found in immunocompromised individuals. Now, this is acute form. It's found in age less than 30. Age must be less than 30 in those patients which are immunocompromised, and it's going to affect your reticuloendothelial system. And in chronic or adult form, primary infestation and pulmonary disease in lower lobes with fibrosis. So, in patients who are not immunocompromised and who are elderly, they're not immunocompromised, but their immunity levels are down now because of their age. Because of their age, the immunity is not up to the mark now. So what happens is that they're not going to get infection of reticuloendothelial cells or reticuloendothelial systems. They're going to get the infection of lungs. And most of them are what? Smokers. So they're going to get this primary disease of lungs due to this pathology. It's going to be ulcerative nodular mucocutaneous lesions in nares and mouth. So it's going to affect your lungs, it's going to affect your nares, and it's going to affect your mouth. Your nares will be affected. They will be ulcerative and nodular mucocutaneous lesions present here. They will be ulcerative, and these ulcerative and mucocutaneous lesions will be present in your mouth, and your lungs will be affected. And most probably, what part of the lungs? Lower lobes of the lungs with fibrosis. It's going to cause fibrosis. So we have this picture of pathology that if a patient presents to you and the age is less than 30, You always suspect it's active and juvenile, and the patient is immunocompromised. And if the patient presents to you after 30s, in mid 40s, mid 50s, mid 60s, it's going to affect its lungs, it's going to affect its nasal nares, and it's going to affect its mouth. How do you confirm the diagnosis of it? First of all, you go for the culture identification, but let me tell you, cultures must be right all the time, but they take a lot of time. They take a lot of time in telling us the diagnosis, in telling us the true diagnosis. It takes a lot of time. We cannot wait for 7 to 14 days for mold to grow and tell us that okay, it's this pathology. So what we do, what other modalities we have? We can go for distinctive shape of yeast, which is going to be what? This form, budded form. Remember this word, it's going to be budded form. Buds will appear. That's distinctive form of yeast which is present in this pathology. Next on, you can go for the tissue biopsy always. Which tissue biopsy you'll go for? You go for the nasal layers which are affected, your mouth ulceration which is affected, and in some cases even the lungs. So tissue biopsy is one option, cultures are option, and you can go for definitely for the shape of the yeast, and that shape will be budded form. Next on, what's the treatment of this pathology? First of all, you start with the itraconazole, ketoconazole, voriconazole, posconazole, and sulfonamides. Now, these are the basic drugs which are used for the treatment. And one other drug, amphotericin B, which is used in kind of all the fungal infections. Amphotericin B is used in kind of all the fungal infections, but amphotericin B is given in very monitored doses, because if somehow there's resistance development regarding the strains of amphotericin B, it's very difficult to treat any kind of antifungal, any kind of fungal infection with any kind of antifungal drug. So these are the group of drugs which are used in this pathology. We have seen that itraconazole was used in sporotrichosis too. We see that amphotericin B was used too, but all these groups were not used, and they're only used in paracoccidioidomycosis, right? So itraconazole, ketoconazole, voriconazole, posconazole, sulfonamide, and amphotericin B are the treatment drug options for this pathology. Next on, we have penicilliosis. Etiology, epidemiology. You tell me what's going to be etiology and epidemiology. It's going to be the same. Only thing that's changing is the organism. Up till now, only thing that changes in this whole scenario is your organism. So what happens is that Penicillium marnefi is the causative organism which will do what? Which will get into your system, which will get through your nasal nares, get to your respiratory system and causes pathology. And its epidemiology is very different from the other other fungal infections. It's also found in Northern American sites, in Southern American sites, and along with them, South Asia. We talked about that it's more found in American countries, but this is the only pathology, this penicilliosis, which is found in South Asia too. Next on, what's the causative organism? You know, this is a farmhouse. We have a horse, we have these farmers working, they're going to be in contact with the soil, they're going to be in contact with other forms which contain this pathogen somehow. So these people are at higher risk of getting this pathology. And from what? From plants, from rodents, from all these things comes this pathogen. These bamboo rats are found where? In the farmhouses. In the farmhouses, they can carry this pathogen. They can carry this pathogen into these places where the people can get affected by them. And what happens in this pathology is that you're going to inhale the same conidia we talked about, inhalation of conidia by immunocompromised individuals. We talked about it again and again and again. Those IFE, first they were being taken up by the person itself, by the soil. Now bamboo rats are coming in, which are causing this pathology. People are working at the farmhouses, which are going to get this pathology, mostly found in southern Asia and American countries, to specific American areas, not all America, obviously. But afterwards, we have this conversion from that form into conidia. Those conidia are these rounded structures we talked about. They're going to get into your nares, and they're going to get into your systemic respiratory system. They're going to convert into yeast and cause this pathology. So organism converted into yeast phase in the lungs, we talked about it, and spread hematogenously to reticuloendothelial system. So we talked about in the last lecture what coccidioidomycosis, and that we talked about that only the active and juvenile phase, or only the patients who are less than 35 and are immunocompromised, are going to get affected. How? Through dissemination. Dissemination affects the reticuloendothelial system, right? We talked about those patients which are not under 35, which are in the mid 40s, mid 50s, mid 60s. They are going to get a primary infection of respiratory system, your mouth, your nares, right? But you had to ponder over that those patients which were under the age of 35 and immunocompromised were getting the infection of reticuloendothelial system. So we're talking about penicilliosis now, and it's only affecting those individuals which are immunocompromised. So what infection you will look for? What infection you will be seeing that happening? Obviously, it's going to get into your systems. It's going to get into your blood hematogenously. It's going to spread it to your reticuloendothelial system, because this patient is immunocompromised individual suffering from AIDS or whatever, other systemic illnesses or other autoimmune diseases. So they are going to get this pathology, and this is going to spread through hematogenous spread and going to affect your reticuloendothelial systems. What are the clinical manifestations you will look for in this patient? You will have fever, you will have weight loss, you will have fatigue, you will have dyspnea, you will have diarrhea, you will have lymphadenopathy, you will have hepatosplenomegaly, you will have these skin lesions, right? So, do you think all of these clinical manifestations will be present in any patient which is suffering from penicilliosis? No. If you look very closely right here, if you look very closely in this clinical manifestations, you'll see a pattern here. Fever. When is it possible that the patient develop fever? When the patient is suffering from hematogenous spread. Weight loss. When the solid organs are being affected, or lymphoid structures are being affected, or your lungs are being affected. When any organ is being affected and your daily routine is being affected because of it, your appetite is being affected because of it, active infection is happening in your body, you're going to have weight loss. Fatigue. Patient will be fatigued, obviously. Why? When it's affecting your body, when it's affecting your lungs, when it's affecting your other organs, lymphoid structures, blood, you'll be fatigued. Dyspnea. Now, dyspnea is a symptom when only respiratory system is being involved, or your circulatory system is being involved. Diarrhea, if it somehow affects your gastro system. It's very rare. Let me tell you, fungal infections affecting your gastro system is very rare, but it does happen, and it will lead to diarrhea. Lymphadenopathy, we talked about, it's going to affect what? Solid organs or other lymphoid structures. So it will lead to lymphadenopathy. And when will that happen? After its hematogenous spread, right? Hepatosplenomegaly, we talked about reticuloendothelial system being affected, right? So when it is affected, it will lead to hepatosplenomegaly. Skin lesions, only in those cases in which skin is being involved, in which only cutaneous layer or subcutaneous layers are being involved. So what we do know is that when it got into your lungs, you will have this dyspnea, you'll have this fatigue, you'll have this weight loss, you'll have this fever maybe, but not all of these. But when it got into your blood, it spread it. It will spread to lymphoid structures and will lead to lymphadenopathy. It will spread to reticuloendothelial system and will lead to hepatosplenomegaly. It will spread to your skin lesions and it will spread to your skin and will cause skin lesions. And what other thing that we're missing here? That if it goes and affects your gastro system, it will lead to diarrhea. So all of these clinical manifestations will be depending upon the spread of this uh, pathogen. If it's spread it to your lymphoid organs, it's going to be lymphadenopathy. If it's spread it to your reticular endothelial system, it's going to be hepatosplenomegaly and all of these symptoms afterwards. So clinical manifestations you will have to look for. These are actually very helpful in getting to your differential and excluding some differentials and getting to the actual stage of the disease. You can actually stage a disease just by looking at the clinical manifestations, right? If it's only affecting your lungs, if it's just sequestrated at your lung level, if it's not going hematogenous yet, you'll have these lung symptoms, but no hematogenous symptoms. You'll not have lymphadenopathy. You'll not have hepatosplenomegaly. You'll not have these skin lesions. But if it has spread through hematogenous levels, you will have these lymphadenopathies, you will have these hepatosplenomegalys and skin lesions if it's affecting your skin. So you can actually stage a disease by this. And how do we diagnose it? We diagnose it on the basis of its biopsy. You can diagnose it on the histopathological slide. And next on, you'll go for the treatment of the penicilliosis patient, which is suffering from penicilliosis. What we're going to do, we're going to start with the itraconazole and amphotericin B. That's all. That's the only treatment we have, itraconazole and amphotericin B. And one thing you have to admire up till now, that all these fungal infections are being treated by itraconazole and amphotericin B, right? All three of these infections we talked about have been treated by what? Amphotericin B and itraconazole. So this is the only pathology that is only treated with amphotericin B and itraconazole. On the other hand, coccidioidomycosis, we saw there were multiple drugs. So you don't give amphotericin B and itraconazole anywhere. Like you don't give it everywhere. Sorry, not anywhere, everywhere. You don't have to give it in coccidioidomycosis. You can give other drugs. Voriconazole you can give. But this is the only pathology in which only these two groups are effective. So you can save these groups for this kind of pathology for later. If this is a person who is being subjected to fungal infections rather more oftenly, you can save these two drugs actually for this kind of pathology in which no other drug will be of any use. Next on we have Phaeohyphomycoses. Now, Phaeohyphomycosis, it has further subcategories. It can be eumycetoma or it can be chromoblastomycosis, right? These are the two subcategories of it, in which eumycetoma, it will affect your skin lesions. It will lead to oma, meaning some kind of tumor, which is benign, right? Oma, but not in this case. It's affecting your skin. It's affecting your skin at a very superficial level. It's affecting your skin in such a way that papules are being developed, and it can affect your knee joint. It can lead to chromoblastomycosis and further on. So what's the etiology of this pathology? First of all, we have eumycetoma, which is caused by what? Medullary species. We have chromoblastomycosis, which is caused by Fonseca, which can also be caused by Cladophilolophora. We have disseminated and focal visceral infections, which are caused by what? Alternaria. We have exophilia, some people call it, but I call it exophilia. It is also caused by exophilia and curvularia. Now, these are the causative organisms. These are etiological features for Phaeohyphomycosis. These are the causative organisms which cause this pathology. Next on, we have CNS and osteoarticular infections, which will be caused by what? Exorolium, or we can call it exorhylum. So, what are going to be the clinical manifestations regarding this pathology? Clinical manifestation will be eumycetoma, will be causing what? Swelling. It will look like cellulitis. It will look like patient is developing cellulitis, but it's actually eumycetoma. Development of sinus tract. Sinus infections will be coming in. Then appearance of grains. What is appearance of grains? It's actually a demarcated surface on the skin. Demarcation on the skin which is caused by this redness. You can see redness, or there will be some kind of small structures, raised lesions which will demarcate the surface. It will be called appearance of these grains. This will be one of the clinical manifestation. Infected bone, we talked about it, we saw in the picture of it, but infected bone, most probably it's going to be your knee bone, knee joint bones are going to be affected. It's going to be infected bone. And next on comes bacterial superinfection. What is bacterial superinfection? It means, actually, the meaning of superinfection is that it's superimposed on anything. It means there was fungal infection, it got the immunity at its lowest levels, and the bacterial infection came in and made a good use of it. Didn't have to face any kind of immunity. So that's what's called bacterial superinfection. On other infection, bacteria come in, and most probably they're opportunistic infections, which take use of this state of body in which it's defenseless. So, in mycetoma, we have swellings, then we have development of sinus tract, we have appearance of glands, we have infected bones, and bacterial superinfection. In the chromoblastomycosis, we have nodular lesions, we have chronic lymphedema, we have bacterial superinfection, and we have squamous cell carcinoma. Now, these are the clinical manifestations of chromoblastomycosis. They are fairly different from the last one, right? So we have these nodular lesions, we have chronic lymphedema, we have bacterial superinfection, and we have squamous cell carcinoma. We talked about this OMA thing, in which we talked about it's going to be benign, but in squamous cell carcinoma can be benign as well as malignant in some cases. So it can lead to squamous cell carcinoma too. Next on, we have this demarcaceous mold, which can cause these nodular lesions, and we have these immunocompromised patients in which it can cause brain abscess, it can cause disseminated infections, and it can cause pneumonia. So this mold in immunocompetent patient will only cause these nodular lesions, but if it's immunocompromised patients, it's going to cause brain abscesses, it's going to cause hematogenous infections. It will lead to, these infections will be dependent upon which organ is being affected, basically, or which lymphoid structure is being affected. And then next on, if it affects your lung, it will lead to pneumonia. So after knowing the three different subcategories of it, and then three different clinical manifestations of it, how do we diagnose it? What's the diagnostic tool for us to diagnose Phaeohyphomycoses? First of all, you go for the histopathological examination. Next one, you go for the microbial culture. Then you'll go for the characterization of the lesion and swelling. These three are the only modalities we have. We talked about that we have to do the basic testing. We have to go for the complete blood tests, RFTs, LFTs, and PFTs, even in some cases. We have to go for all of them. But when we are done with all of that, and our differential is only this fungal infection, regarding that, considering that in mind that it's a fungal infection, you'll go for the histopathological examination, you'll go for the microbial culture, and you'll go for the characterization of the lesions and swelling. Now, culture will be coming late. What we have as an early indication of some diagnosis is characterization of lesions and swelling and histopathological examination. What's the treatment in this patient? Treatment is going to be fairly different in all three cases. In mycetoma, the treatment will be what? Surgical extirpation of lesion and antifungal agents. You will remove that lesion. You saw that lesion on the foot, right? Those papules, those lesions. You will surgically remove them and give antifungal drugs so that if there's any hematogenous spread, or if that organism is present anywhere else in the body or going to cause any kind of pathology, it's treated. It gets eliminated so that it doesn't cause any further pathologies. In chromoblastomycosis, What we do, we go for the surgical extirpation of lesion, if there is any. If the lesion is present on the foot, you have to extirpate that. You can go for the cryosurgery, you can go for the laser therapies, you can go for itraconazole, voriconazole, postconazole, flucytosine, and terbinafine. Now, these are the antifungal agents. It means that it also has to do with the surgical extirpation with cryosurgery and laser therapy and antifungal treatments. Next on, we have disseminated and focal visceral infections. Now, the treatment for them is itraconazole, voriconazole, and postconazole. They don't involve any kind of surgical expiration or cryotherapy because they don't have any skin lesions involved with them, right? So that's all for today regarding systemic mycosis. We talked about what systemic mycosis is. There are going to be other lectures regarding systemic mycosis and other further subtypes of it. Today we talked about basically 4 different types. We talked about how these fungi are going to get into your system. They're going to be hyphae. They produce these conidia which get into your systems. And if patient is immunocompetent, in 95% cases, we won't even know this infection came into happening. We won't even know because it's self-limiting and it's going to be asymptomatic as well. And if there is to be any pathology, it's going to be only nail pathology, mouth pathology, and respiratory pathology. There won't be any dissemination. But if the patient is immunocompromised, it's going to be disseminated. It's going to affect your reticuloendothelial system, basically. And what does happen afterwards is that it can affect your bones, it can affect your lungs, it can affect your spleen, it can affect your liver. All of these structures can get affected, and as well as other lymphoid structures, and will lead to lymphadenopathy. So what we do for the treatment for all of them is we start with antifungal drugs. Basically, we give amphotericin B and itraconazole, but for different organisms, for different pathogens, we have different specificity, we have different sensitivity of drugs. So we have other options of antifungals to give. So we start with antifungals, and if there's no skin manifestation, antifungals are enough. If there's skin manifestation, you go for cryosurgeries, you go for the expiration and other modalities for removing that skin nodule or papule or whatever it is. So antifungals are the basic treatment for this systemic mycosis category pathologies. So that's all for today. Thank you for watching sqadia.com.